blood glucose immediately. Look for seizures, subtle signs I will show you later, but you need to have an EEG in place if there is an acute deterioration of sensorium. Head to toe examination, the skin injury, pressure sores, especially in old neurology patient, because they often come with pressure sores, vital signs, pain score important, the systemic vascular, cardiac examination, respiratory, abdomen, girth, detailed neurological examination. Higher mental functions, you may not always be able to do it immediately, but then conscious, unconscious, GCS score or the 4 score important. Cranial nerves, of which the second, third, fourth, sixth, seventh cranial nerves, very important. Motor and sensory examination. In neurology, anything is looked for asymmetry. One side moving more than other side, upper limbs moving more than lower limbs, or right moving more than left. Important. Cerebellar signs, you may not always be able to make your patient walk, so you have to look for the nystagmus, etc. And involuntary movements, very important, because involuntary movements have to be picked up by you. Always think of opioid or benzodiazepine overdose in any acutely obtunded patient. What are the basic serum chemistries you will send? ABGs, urine toxicology screen, of course, in selected cases. Now, this why an ECG is very important even if the patient is acutely obtunded. This we had a young fellow, middle-aged man who came with quadriparesis. So we did the ECG first, and you might appreciate the U wave in the V2, V3 leads as well as V4, V5. Okay, and what came out? You might be jumping to do NCV CSF. The potassium was to 1.2. He had a hypokalemic periodic paralysis. So very simple, very few examinations. And this is a pain scale that from our chart. This is for the patient who can indicate or talk, and this is for the mechanically ventilated patients. You look at this visual analog score and do that. So localization, grossly, the cerebral hemisphere deals with higher functions, consciousness, wakefulness, alertness, and the brainstem with the basic functions of respiration and movement of the limbs, respiration, as well as cranial nerves. And the spinal cord, roots, nerves, neuromuscular junction, and the muscles come on in order. Now, why is the skin important in neurology? Acutely ill neurological acute encephalopathy, if you have any mark like that, herpes zoster. So varicella encephalopathy, very well known. Chickenpox encephalopathy, well known. Muscle weakness with Gottron papules. This is dermatomyositis. Look at this man with the lateral bite on the tongue. Bite on the lateral side of the tongue. Pathognomonic for a GTCS, right? These are burn injuries on a patient who had a stroke on the left side, and she had hypoesthesias on the right limbs, and she burnt herself. And this is piloerection. This is very pathognomonic in an otherwise normal environment for an autoimmune encephalitis. And this is hypoaesthetic patches on which is leprosy or Hansen's disease, very important in neurology. And look at this. These are pressure sores due to TED stockings. And this patient was paraplegic, so never miss all those. And this is the phenytoin extravasation on the hand. So these are some gory pictures of neurology. Now coming to general and neurological examination, look for signs of trauma like wounds, bleeds, swelling, fractures, ecchymosis, Bannon's eye or raccoon's eye, tongue bites. Vital signs, temperature may portend sepsis or CNS infection, or hypothermia may lead to even maybe in sepsis, myxedemial coma, hypothalamic lesion. Blood pressure rise, Cushing's reflex, and hypertensive encephalopathies, subarachnoid hemorrhage, or low pressures in intoxication often. Respiratory rate is very important. Hyperventilation in acidosis, fever, brainstem lesions, hypoxia, hypoventilation, intoxication. Respiratory patterns, I will come to later. Severe excruciating worst pain of life is subarachnoid hemorrhage. Look at the face for asymmetry, motor response, asymmetry, cranial and peripheral nerves will come, reflexes. So ICP, raised ICP requires a high index of suspicion involving pupillary change and Cushing's triad of bradycardia, hypertension with high systolic and low diastolic pressure, and irregular respiration. So you need to be careful when you are looking at an acutely confused patient. Now, neurological examination in the ICU is mainly determined by the level of consciousness. Where you have the conscious patient, you will ask questions, orientation, language, attention, coordination. But in unconscious patient, you will look at the level of arousal determined by the GCS of the force score. Brain stem functions are the next. Motor response is the next. Respiratory pattern you will look for. Look for abnormal movements. So first you start with a voice command of "Are you okay?" progressing to louder voice. If not, then physical stimuli, which would include a sternal rub or a trapezius squeeze or a nail fold pressure, right? That is how you go about. Conscious patient, I've said, it's an acutely obtunded patient, so you may not be asking questions often. So we come to the Glasgow Coma Scale, of which you are all aware. The eye response 1 to 4, spontaneity to no eye opening, motor response, obeying commands, 2, 1, no response, verbal response, orientation to no one response, or if the patient is intubated, you cannot take this response. Brainstem reflexes are not covered in this GCS score. This is a disadvantage. Respiration is not considered here, which is a disadvantage. And the lowest GC score can be evaluated with force score, which is another scoring tree. So the GCS is the only one very validated scoring system in traumatic brain injuries, where less than 3 is the least, which is, the GCS score. Less than 8 is severe trauma, and 15 is the normal score. So force score is the full outline of unresponsiveness, where you have eye response, eyelids open, spontaneous, open or tracking or blinking to command. 3 is open but not tracking. 2 is closed but opens to loud voice. 1 is closed but opens to pain, and 0 is remains closed with pain. Now, motor response is 1 is thumbs up or plain hand or peace sign. So he's obeying. 3 is localizing, and 2 is flexion, bad sign. 1 is extension, worse sign, and no response, or myoclonus. Now, brainstem reflexes, pupil and corneal reflexes taken care of here, both present. 1 pupil is wide and fixed, bad response, 3. And 2 is pupil or corneal reflex absent, and 1 is pupil and corneal reflex absent, and 0 is absent pupil, corneal or cuff reflex, which is bad. Respiratory pattern I'll show again later. So here you get a detailed information on brainstem responses, and it helps you in the locked-in state where you have eye responses, but the patient is quadriplegic, not moving any limb. He cannot obey any command. He cannot move his head, but he can do eye movements. So this helps in scoring. Now, the force score has not yet been included in traumatic brain injury severity scales, but it will soon be, I guess. So next, after you have tested the cerebral arousal or awakefulness, alertness with the GCS and the force score, you come to the lower brainstem where you have the cranial nerves. Now, cranial nerves are arranged in pairs in descending order. So there are 3 sensory nerves, 1, 2, and 8. 1 we will not be testing in the acute emergency situation. 5 motor nerves, 3, 4, 6, 11, and 12. And mixed motor and sensory is 5, 7, 9, and 10. Usually, ipsilateral defects are produced in dysfunction. Now, the 4th cranial nerve arises from the posterior side of the brainstem. But because of its long course and it crosses, the compression typically occurs after the cross. The symptoms, right? Hernia comes one above through the second, third nerve gets lost from the 3 to 12 accessory where between the 10 and 2. So since cranial nerve 3 is the most important test in critical, it lies at the level of the tentorium from where the herniation occurs. So unilateral dilated pupil, pick up your socks and run to get emergency care. Asymmetrical loss may indicate unilateral compression. So the brainstem reflexes may be absent. Be careful in hypothermic patients a few hours after cardiac arrest, or in patients who have received blockers. So you cannot assess them immediately. Now, brainstem reflexes actually test the afferent limb, the nuclei, and the efferent tract. What are the things we see? The pupillary size, reactivity, symmetry of the light reflex, response to visual threat, because you cannot test the visual acuity in your ill patient. Corneal reflex, the Doll's eye, the oculocephalic reflex, but be careful. You cannot do it if the C-spine is not cleared. Ocular vestibular or caloric reflex, this we do usually in the case of brain death, but it is a huge chapter. We will not go into it that now. And gag and cuff. Cuff, when you suction, you can see whether the patient cuffs or not. And gag, for that you have to stimulate each side of the pharyngeal wall simultaneously. You look at the contraction of the posterior pharyngeal wall and the movement of the uvula. Now, this is a picture of the brainstem. You look at the olfactory nerve, we will not be able to test in critically ill. Optic nerve and the oculomotor from the midbrain, trochlear and trigeminal, the abducens from pons, facial nerve, vestibular nerve, glossopharyngeal, all along the pontomedullary junction. The vagus from the medulla, the accessory nerve rises up and places itself between the vagus and the hypoglossum, and the hypoglossal from the medulla. And this is the arrangement of the cranial nerve nuclei. This is the midbrain, the pons, the medulla, right? So when you look at the next, you come at the, before you look at the pupils and the eyes, the light reflex, you look at the eyes. Spontaneous roving eye movements means bilateral cortical dysfunction, but the brainstem is intact. Disconjugate, there is a structural metabolic process or extraocular involvement of the third nerve to sixth nerve, or psychoactive and anti-seizure drugs have been associated with the depressed vestibulo-ocular responses. That is Doll's eye, right? Spontaneous eye position, you might look for nystagmus or completely immobile eyes, which may happen in intoxication, brainstem injury, or a neuromuscular blockade, right? And jerky nystagmoid movement may be seen in non-convulsive status epilepticus, brainstem, or cerebellar ischemia. I will show these two in videos later. Now we will look at the pupils next, the shape, size, position equality, and the light reflex. The light reflex, as you know, tests the second and the third nerve. Third nerve also deals with the medial recti, that is downward, downward, outward movement of the eye, and the eye movement in all directions except the lateral rectus and the downward inward movement. As you know, it is all three, SO4, LR5, LR6, that is lateral rectus is sixth nerve, and superior oblique is fourth nerve, which is downward inward movement of the eye. The rest of all is controlled by the third nerve. The facial movement, you can see the asymmetry of the face, the motor movements, but salivation and sensation you may not be able to test in your acutely ill patient. Eighth nerve, we will look at the Doll's eye and the cold calorie, but cold calorie is done only in case of brain death, right? And the 11th and 10th by the gag response. 12th nerve, hypoglossal nerve, you can grossly look at the tongue to see whether one side is wasted or not. That will give you a clue. So these are the kinds of pupils you have. In midbrain tectum lesion, you have dilated pupils, unreacted, right? Tegmentum, which is the lower side of the midbrain, and the pons, you have smaller pupils, irregular, unreactive. And in pontine lesions, you have small, pinpoint, responsive pupils, right? Now, hemispheric lesions, sometimes you have gaze preference. Both the eyeballs are rotated towards the same side of the lesion, sometimes on the opposite side of the lesion. In tectal area, you have the eyes downward. Tegmentum, unequal sides, one side down, one side up. One's right third nerve lesion, one pupil dilated with ptosis, the next eye is normal, right? If you look at this eye, can you put it into any one of these categories? Not really. Why? Actually, this eye is an artificial eye. That's why. So should not miss all these nuances, you know. So light reflex, you shine a light into one eye and look for the pupillary reaction in both eyes. If the pupil reacts to light shown in either of the eye, then probably the third nerve is not the cause, right? Eye movement, extraocular movement, once again, taken care of by the third nerve, fourth nerve, sixth nerve. So you look at all directions, lateral, medial, upward, downward, grossly. They should be moving together. Disconjugate movement will lead to diplopia, either of these dysfunction or the involvement of the muscles of the eye. Look for nystagmus, which may be normal in extreme horizontal gaze, but never in the vertical gaze. Now, how do you look for corneal reflex? At the corneal and conjunctival junction was a wisp of cotton, and it is taken care of if you by the fifth nerve and the seventh nerve. If you stimulate one side, the seventh nerve supplies both eyes, and the eyes will close to protect the eyes from any noxious stimuli. Doll's eye reflex, I will show you how we see it. When the head is turned, the eighth nerve is activated, causing the eyes to move in the opposite direction. And it is a communication which happens between the sixth and the sixth, eighth, and the third nerve to produce the horizontal eye movement. But of course, C-spine to be clear. Now, vertical eye movements, it actually is located at the top of the brainstem, third nerve, and it also involves the frontal lobe of the eyes, because frontal eye fields by connections. So we need to look at all that. We won't go into details because that will be too much. Now, look at this video. GCS response, not responding, E1. The eyes should be open in order to see the E1. Not moving any limbs. So you have to expose the limbs, otherwise you cannot judge. She's not moving, she's E1, M1. And of course, she's intubated, so we cannot assess. Look at the pupils, the eyes, the left eye slightly disconjugate eyes, that means brainstem involved. There is no pupillary response, bilateral dilated pupil not reacting to light, right? So the third nerve is gone. Look at the doll's eye, not moving really. Now here we stopped because she started coughing. So the lower part of the 10th nerve, 11th nerve, are still intact. So we stopped at this. So she has a cuff reflex, but which is not going to last, because this is a CT scan, a huge grade 4 subarachnoid hemorrhage with an probably the aneurysm lies here, large bleed which has already crossed the midline, and she has already dilated. So both the pupils are dilated, not reacting, but she will herniate further to lose her cuff reflex, which she did subsequently. Now, the cold calorie, just learn it that you have to check the integrity of the eardrum. In a weak patient, you cannot do it, causes vertigo, nausea, vomiting. You elevate the head and 30 degrees cold water into the ear of the unconscious patient. The eyes deviate towards the irrigated ear. If they remain in this position and then return quickly to mid position, that is normal. If you observe for 1 minute, but wait for 5 minutes till you test the other ear. Delayed movement or recovery will indicate abnormality, and a fixed position will indicate brain death. So in brain death, bilaterally it will be lost, but in unilateral loss, it may be a structural lesion on one side. So the pupils, once again, to revise, pinpoint opioids, cholinergic intoxication, pontine damage due to some cause, ischemia, infarct, anything. Dilated, non-reactive, drugs, cerebral ischemia, hypothermia, brain death, damage to midbrain or third nerve compression. Dilated reactive pupils, pretectal lesions, or some stimulants like cocaine, methamphetamine, hallucinogens. Pupillary asymmetry is third nerve compression from uncal herniation, I'll show you. Or never forget, your ophthalmologist may have dropped the tropicamide solution into one eye and seen the eye and gone off, right? Mid position fixed or irregular pupil means midbrain lesion. In hypothermia, you have small unreactive pupils, but in metabolic encephalopathy, they will be reacting. So you have to pick up these, but it is individually, it varies. That is why you have the pupillometer in place. Now look at this lady who has a dilated fixed left pupil. So, but she is conscious. So where is the lesion? Lesion is in the nerve or the midbrain, and that is the cavernous sinus region. Here is the normal atlas picture of the cavernous sinus with the oculomotor nerve, the trochlear nerve, as well as the ophthalmic nerve. So all these nerves are encased. So is the internal carotid artery over here. But the left lesion is larger than the right. So the left oculomotor has gone for her. The right, although, and she has ptosis on the left side, although she has this ptosis is more than this ptosis. Look, so this side is less affected. That is why her right pupil is smaller, and there was some reaction, although she had paresis, gaze paresis. So these are subtle signs you must look for. Now look at this man. Look at the eye signs. That's what I'm trying to tell them. So you will find that the patient is really not moving his eyes much. You can see that he's already tracheostomized. He was quadriplegic. He's moving his head, but not his eyes. And there is bilateral ptosis, which is unequal. Look carefully. And his pupils were unequal with poor reaction. He is actually not looking. He is listening to it and trying to move his head. He was quadriplegic with eye signs. And when he came, he actually visited the psychiatry OPD first with hyperventilation. They thought it was psychiatry, but look at his, when he went to the neurology, they found him quadriplegic and obtunded. Look at his ABG, 7.54, 20 PCO2. He was hyperventilating like hell and with a bradycardia. But no hypoxia, look. So where is the lesion? Quadriplegia, brainstem signs, hyperventilation. Lesion is in the brainstem. These are FLAIR images. You will appreciate medulla, midbrain, pons, entire thing. You can see the arrow over here. This is a NMO positive brainstem encephalitis, NMO, autoimmune encephalitis category, right? So cannot afford to miss it. Now, these are the eyes which were because of the ptosis and the exposure, and he had no corneal reflex as well. So they led to exposure keratitis and hypopyon. So be very careful when dealing with such patients. You have to protect the eyes properly. Now, I was talking about uncal herniation. Now, this is the uncus of the brain brainstem. If there is a lesion over here, it will press the uncus. The third nerve will first go this side, dilated pupil on the right side, and with more compression, it will dilate the left side as well, and will lead to bilateral dilated pupils, and then the lower brainstem goes. For example, the subdural in the CT scan, you cannot see the lateral ventricle horns over here because there is a large mass effect, and that is led to the uncal herniation. So the right nerve pupil will be dilated here. Look at this case: 32-year-old man assaulted, unconscious, moving right limbs less, GCS of 6, so severe head injury, pupils are equal reacting. This is not his picture. I will show his picture later. Now, what happened? He went to the CT scanner. The moment he came back, the left eye was dilated, fixed, not reacting. The right eye pupil was normal size, reacting. So where is the lesion here? Look at the huge subdural on the left side pushing the ventricle. There is a subdural here too, but the left eye is getting dilated. So they did a burr hole immediately, releasing the pressure from this side first and then the right side. So that is how you take decision. Huge intracerebral hemorrhage leading to midline shift. This part of the ventricles are compressed. So this uncus is always, there is uncal already herniation. So this is necessary for dealing with intracranial pressure. I will talk about that later. Examination of the fundus is important in neurology patient. This is a normal fundus. This is papilledema. This is actually subhyaloid hemorrhage and subarachnoid hemorrhage patients, which you don't pick up usually. This patient came to me from Bangladesh, and they had captured the picture. So that's why I put it over here. So fundus examination important, but of course, be very careful, wear masks, and protect your eyes, because if there is a meningitis, you might be contracting some infection. The automated pupillometry, in order to do all this pupillary reaction, etc., you need a lot of individual involvement, and which varies from person to person. So this gadget has come up, and we are going to get it very soon in our hospital, where it records the light reflex, the velocity, the percentage of constriction and dilatation of the pupils, and it compares, and it has a record over time. So it helps in predicting which patient is going to have raised intracranial pressure, what is the pressure, tracking the pressure, and who is going to herniate. And that is called the neurological pupillary index, value ranging from 0 to 5. Normal values more than 3. In raised ICP, it is less than 3, and it detects raised ICP earlier than your manometer or your CT scan. And it helps in prognostication after cardiac arrest. Now, we have finished the cranial nerves more or less, but we will do the respiratory pattern and the muscles a little later. Now, come to the motor response. Now, you do a sternal rub to find out all 4 limbs moving or not, right? So, if you ask your patient to allow obey commands, axial, sticking out tongue, or showing 2 fingers, or pushing the examiner away, this is or localizing nauseous stimulus, this is a purposeful movement. Non-purposeful movement is a reflex withdrawal, flexion, or extension posturing to a painful stimulus. Now, if your patient is grasping but not allowing you let go, then that is not a normal response, right? And you look for deep tendon reflexes, asymmetry, and of course the plantar response, because upgoing plantar means that is a upper motor neuron lesion. How do you test for tone? You flex, extend your limbs passively. Spasticity is corticospinal tract. Rigidity or spasticity, there is a catch in the flexion extension. Rigidity is extrapyramidal, lead pipe. Throughout, you will have increased tone. And flaccidity, you will find in cerebral or spinal shock stage or peripheral neuropathies. Now, there are two posturings, decerebrate and decorticate. Decerebrate is the insult in the brainstem between the superior and inferior colliculus. All four limbs and neck are stiffly extended. That may lead to opisthotonus as well, right? This is bad. And decorticate is found in most often in cerebral strokes, where you have flexion of the upper limb, extension of the lower limb, because anti-gravity muscles are hyperactive, and this means the cortex function is bad, and this means that the brainstem function is getting worse. So, sorry. Look at this. This young girl from anoxic brain injury. Look at her decerebrate posturing. The brainstem, she has got hypoxic lesions on the CT scan. Look at the posturing. Hyperextension, eyes looking towards one side, but she is actually not obeying anything, or these are all just the eye movements are there. But her posturing indicates there is severe brainstem damage, right? And she had severe dysautonomia, rise of blood pressure, hyperventilation, tachycardia. Look at the legs. Eyes deviated to one side. Very sluggish pupillary response. She is into her 4th week, actually, and she's still admitted with swings of dysautonomia. Look at the CT scan. The thalami, the basal ganglia region already infarct, showing ischemic changes. Look at, you cannot see the sulci-gyral differentiation. And that in a young girl like this portends very bad prognosis. Even the brainstem showing ischemia. And this is the MRI diffusion weighted imaging showing signal change in bilateral basal ganglia, thalami, and the posterior circulation region. That means she has suffered severe, these are the oxygen sensitive areas, severe hypoxic brain damage. Now, we'll look at the respiratory muscles, the internal, external, and intercostals from the thoracic level, innervation. Weakness will cause intercostal space retraction with bulging and retraction of the epigastrium in inspiration. And the diaphragm, which is supplied by the phrenic nerve 3 to 5, increases the vertical diameter of the thorax. In diaphragmatic weakness, epigastrium will not bulge in inspiration, and the cuff is weak and a weak sniff. So look at it, the intercostal weakness. This is actually weakness of both the diaphragm as well as the intercostal muscle. In between, you will find during inspiration, the epigastrium does not bulge, and in between, you will find that it occasionally bulges. So he was complaining, I am unable to breathe, I am unable to breathe, and we intubated him subsequently. Not much of movement in the thorax, right? So that portends muscle weakness. Now let us look at the respiratory pattern. The Cheyne-Stokes respiration. Respiration, no respiration. Again, clusters of breathing, then no respiration. This indicates global. This you will find on your monitor if you have the respiratory plug switched on. then you will find this kind of patterns coming on your monitor. Unfortunately, I could not find out the video which had this kind of record. So it is global metabolic encephalopathy or a forebrain lesion. Now, in hyperventilation, like that fellow whom I showed you, indicates these kind of hyperventilation may be in severe metabolic acidosis as well, or a pontine or midbrain or brainstem lesion. Apneusis, that is no respiration, then sudden there is a buildup of carbon dioxide, then it stimulates the brainstem, again one respiration, again apnea. So that is bilateral pontine lesion. Cluster breathing is typically the pontomedullary junction, it is almost like a clonus. And of course, in the medulla is the place from where the respiration starts. So if there is apnea, means the medulla is gone. Now, we've finished the muscle. We will talk about the muscle power grading later when we talk about muscle weakness in a couple of slides. Let's quickly go through the abnormal movements in the ICU, of which you should know dystonia or sustained twitching movements or prolonged tonic posturing, which happens in basal ganglia lesions, spinal cord lesion, brainstem lesions as well. Myoclonus is very sudden, jerky, brief, involuntary movements, which is very actually originates from cortex, basal ganglia or even the spinal cord lesions can cause segmental myoclonus. Myoclonus after a cardiac arrest portends worse prognosis, right? And never forget the non-convulsive status epilepticus, where you will not have convulsing or seizure movements of the limbs, but you have to pick up the unilateral eye deviation, lip smacking, automatism, some movements of the fingers, and these are all, of course, cortical in origin. Sometimes patient is just unconscious, you cannot pick up any movement, and then you will have to do an EEG. The NCSE is actually picked up by the EEG. Now look at this abnormal movement. This is, she's simply trying to chew away her lips. This is typical of autoimmune encephalitis. In a young girl like this who has presented with convulsion, you might be foxed. Probably this is a convulsion. No, look at her hands. They are not moving. This is automatism, right? Look at this young girl. Look at her lips, very subtle movements. She's actually conscious and trying to obey commands. She's not having any convulsion. She was trying to look at the voice. I've switched off the voice just so that we are not getting. Look at the movement. This is actually not a convulsion because she was conscious and she was obeying commands. She was totally obeying commands. These are automatic movements seen in autoimmune encephalitis. When you ask her to hold her hand up, she does it. So this is automatism. Look at this young boy with scrub typhus encephalitis, bilateral thalamic lesion. He had an NCSE as well, but what was happening? Is this a seizure or not a seizure? We did an EEG and there was no discharge on the EEG because he was already on anti-epileptic drug. But this is thalamic posturing and dysautonomia, where there is posturing, hyperventilation with rise of blood pressure, tachypnea, and sweating, severe sweating. So this is dysautonomia. This is important, very important video. Look at this. This man was actually a doctor in training. Look at the eyes and look at the hands. Pick up the subtle movement. You might think he's just moving it. Not at all. He's actually not conscious. Look at the subtle eye movement. Look at the subconjunctival hemorrhage because of repeated convulsion. This man had non-convulsive status epilepticus. So these were small movements which were happening later, and he had breakthrough seizures, right? So never miss them. Look at him again. Look at the eyes. Never missed his eye. Think conscious, but no, this is convulsion. Look at the nystagmoid movement of the eyes, slight jerky movements. So these are convulsion. How do we know it? Because the more you see, you will learn. And look at the EEG of this fellow, full of discharges, and you give a test dose of 4 milligram of lorazepam, they are gone. So that's how you pick up non-convulsive status epilepticus. Now, coming to the sensory system, when you put in a painful stimulus, you can see whether it is very difficult to assess it in critically ill patient, but you can just find out whether they are accepting the pain on one side or not. But we will not go into details. Now, coming to having seen all this, GCS, the cranial nerves, and the NCSs, which patient and what imaging, if at all, have to be done? CT scan is the preliminary imaging, which would pick up any hemorrhage, any small bit of hemorrhage picked up by CT scanners immediately, and it picks up the cerebral edema. Angiography for aneurysm or subarachnoid vasospasm, or vascular imaging for cerebral venous thrombosis, very important. But the MRI has greater sensitivity for early strokes, early infarct especially, and for structural and brainstem lesions, right? In CT scan, you will find this kind of things: subdural, uh, uh, epidural, frontal hemorrhages post-traumatic, large left MCA infarct, left BG bleed, basal ganglia hemorrhagic strokes, subarachnoid. Where do you find an MRI would be better? Acute neurodeficit, acute change in mental status. CT is non-contributory, refractory status epilepticus, osmotic demyelination, posterior reversible encephalopathic syndromes, ischemias, post-hypoglycemia, post-Kruger's, sepsis, etc. And wherever there is a immunocompromised patient with altered status, definitely MRI helps. Special consideration in your acutely obtunded patients. When you suspect mass lesion or a raised intracranial pressure, please be careful about head position at least 30 degrees up to decrease ICP. Take care of blood pressure. If there is an external ventricular drain, be very careful. And the ventilator the parameters, and be ready for seizures. So have SOS medications, lorazepam in hand, definitely. What about pregnant patient with acute encephalopathy? Think about cerebral venous thrombosis, posterior reversible ischemic syndromes, eclampsia or Wernicke's encephalopathy, but be careful about CT scan in pregnancy. We will talk a few things about acute muscle weakness in the ICU. I don't have much time, so I'll run through. Symmetrical reduction in limb and respiratory muscle strength. We have the MRC Medical Council grading. So the differential will be muscle weakness is hypokalemia, rhabdomyolysis, nerve compressions. But you can exclude ICU acquired muscle weakness if you have a positive plantar response up, spasticity, fasciculation. So these cannot be ICU acquired muscle weakness, right? So this is the muscle grading, from 0 to 5 is how you test it. Now, criteria for electrophysiological testing of the nerves. Let me just summarize that if the velocity only is decreased, it's demyelination. If the amplitude is low, then it is axonal. And repetitive nerve testing is done for myasthenia. Sometimes, patient myasthenic crisis comes with only respiratory acidosis. So in that case, if the patient does not come out of ventilator, you can test for myasthenia definitely, right? Assessment of delirium is another spectrum of acute obtundation in the ICU. So alteration, we did the definition first. This delirium is very important because it portends increased morbidity as well as neurocognitive dysfunction later on, even after discharge. So you have two scores. I will come to the scores where there is a disturbance in attention for a short period of time, and the cognition not explained by other pre-existing conditions or a neurocognitive disorder, or is not a direct physiological consequence of another medical condition or an intoxication or withdrawal or drug, then you think of delirium. There are two scales, the CAM score, where it requires patient participation, but the intensive care delirium screening score does not require patient participation. Now, having said all this, what is the prognostic value of neurological examination? Because they are the cornerstone in traumatic brain injury, the GCS pupillary reflexes have been found to be validated for prognosticating TBIs. Post cardiac arrest, similarly, abnormal posturing or the myoclonus, bad sign. Force score, again, morbidity, mortality. Absent cuff or ocular reflex in sedated patient means increased mortality. Delirium itself, neuroprognostication is poor, right? Now, just what are the new gadgets for the multimodal monitoring? The intracranial pressure monitoring devices are in vogue. Similarly, cerebral perfusion pressure you can measure. But brain tissue oxygenation, the SGBO2 microdialysis, and the brain tissue injury biomarkers are not very widely available. The optical ultrasound has come up a big way, similar as the transcranial Doppler. The different ICP monitor, we do the Codman, which is the intraparenchymal, or when we have an external ventricular drain, we can do that. Now, I'll just, if we have time, I'll just show you three cases. This is this lady, 48-year-old with no known comorbidities, actually came with a large right MCA infarct within 36 hours. She was beyond the thrombolysis. In acute stroke, you have to do the NIH's score, if you want to revascularize. But she had no large vessel occlusion, probably a cardioembolic stroke. But whatever it is, she was beyond revascularization. So just look at her resident trying to do a good neurological examination. You will find she was good to, obey commands. The left facial weakness, which is upper motor neuron, stimulation to emit a vocal response, eye opening to verbal or painful stimulus, but she was obeying. Eye signs, but she is not obeying all commands, although she has no eye extraocular movement involvement, right? She's trying to look at the facial weakness. Testing for the tone, that's how you do it. Motor response, trying to ask her to hold the lengths, but this is not enough. You have to allow her to let go as well. There is something wrong over here. Never tie the BP cuff on the paralyzed side. The left side is hemiplegic. It is zero power, actually. Neurologists are very want to check orientation, everything together, and you test for the tendon reflexes. Zero response. That's how you test for the tone. You can find that the left tone is more than the right. And look for the tendon reflexes. So you find that the right limb jerks are good. Similarly, simultaneously test the other side as well. Brisk, more than the right side. So she was beyond the cerebral shock stage actually. So the knee jerk. For intensivists, we may not be looking at the ankles always because we are only bothered about gross things, and look at the plant. So that's a good upwing planter. So if suppose this lady did not have this lower limb, she had suffered from amputation, how would you test? Then you look for other signs like you tensor fascia lata or something, you strike it and then see whether it goes up or not. So you do it the other way, but you have to do the eyes first and then come to the motor, right? Okay, let's see what happened to this lady. Now, this is the picture of the intracranial compartments. Now, one compartment, if the brain gets infarcted and increases, the swelling increases, it occupies more space, which will compromise the CSF and the blood space. So then the cerebral perfusion pressure goes down. So this is not this lady's, another lady whom we got with, who came unconscious. Now, you cannot make out any sulci gyri. It is totally edematous. This unfortunate lady probably had meningitis, but she came coning, and she later had cerebral ischemia because of coning and raised intracranial pressure. She has developed infarcts in bilateral occipital lobes. So these are this is a picture of the pupillometer I told you, and this is a picture of the optic nerve sheath diameter, how we measure it. And let us look at this lady who came with the large right MCA infarct. The next day, her infarct had increased in size, and she underwent a large decompressive craniotomy. A good craniotomy has been done because here you cannot see the right lateral ventricle. The pressure has been released from the brain. It is now visible. And post-op, her heart rate came up from 58 to 99, right? And she was a good M6. Good M6. Right. Now, on the contrary, the right MCA strokes can speak most often, and decompression helps them. What happens? This is the picture of the artery, M1, M2, M3, and this lady has blocked the entire MCA from the stem. Comprehension is poor, and she neglects her right side. That is why I stood on the left side to talk to her. But she is not comprehending at all. So these are the signs which you will get in MCA territorial strokes, right? Now,
so we just stop
yes,
because it's already 2:36.
okay, okay, sure.
Yeah.
This is just ACA infarct, and I'll just show you one interesting MRI. The lady came with obtundation and eye signs and no other history, and this is the tactile flare signal changes, typical of thalamic change. This is Wernicke's encephalopathy. She had a gastrojejunectomy and severe thiamine deficiency. So This is how you run through and look for signs, take a thorough history, do meticulous and thoughtful investigations, and daily chart revision and rational treatment. And that, I think, should take care of your neurology patients. So I'll stop there.
Yeah. Thank you, Shobana. Thank you very much for your excellent presentation for the
Thank you, sir.
students of our DNB Critical Care. Just few questions about this. Uh, the ICU perspective of altered sensorium is little different than neurological, that we all agree. Especially
Yes,
this situation comes after prolonged sedation and maybe neuromuscular paralysis. So,
yes,
your protocol, for example, you have treated patient with either traumatic brain injury or subarachnoid hemorrhage or IC bleed for 2 or 3 weeks in the ICU, and he or she requires prolonged sedation for ventilatory purpose. And now you have stopped sedation and you want to do assessment. So, what is your sedation plan for these patients, and how you assess this? This is a quite everyday problem for most of the intensivists.
usually for sedative agents, we try to, until and unless there is a convulsions or status epilepticus, we try to avoid midazolam. Preferably dexmedetomidine or propofols. Propofol is better because it take care of the intracranial pressure also, but then it cannot be used for too long. So in that case, often in TBIs, when we need to we need a prolonged ventilation. There we do need to give midazolam, but we do stop it every day to assess. Early in the morning, we ask the nursing staff to stop it, and by the time the people are on rounds, the midazolam effect gets decreased and we assess. But then the pupillary response is not much affected by midazolam until and unless there is a brainstem injury, of course. So the scale should be there. The analgesia scale should be there to assess whether it's a light analgesia or a severe, deep analgesia. Accordingly, then you plan out. Because obviously, if there is a raised intracranial pressure, we don't want to stop the sedation, make the patient cough, and have a sudden rise of intracranial pressure. And this is for neurological patients. But for other ICU patients, I think there is no problem if the patient coughs.
Yeah. And just last question is, unfortunately, there is increase in number of young population consuming so-called recreational drugs, cocaine,
Right.
vitamin, and lot many things, which was unheard 10, 15 years back in our ICUs. But so, what are your recommendations or suggestions for substance abuse patients coming with abnormal neurological symptoms and signs?
Uh, for any person, for especially, I would not just stick to young patients, even elderlies these days who live alone. Uh, if they come obtunded and you cannot match it up with anything else, there is no suggestive history as such. And usually they do not have any localizing sign. It's a generalized uh, quadriparesis or unresponsiveness. There might be pupillary signs which may uh, portend a cocaine abuse or something where you have pointed pupils and all. But for the rest of it, usually you can, from the very look of the patient, when they do not localize or do localize, but there is no unilateral signs as such, think of toxicology. In that case, we need to go back and ask the family once again, have you found anything in the room? Any tablets, strips, empty bottles lying around? And you go for a toxicology screen. Unfortunately, the normal urine toxicology screen, which is available in the hospital, that just covers, few things. It doesn't
Yeah.
cover many of the things. So it is your insight which will give you. But more or less, you can find out that there are no lateralizing signs as such. It is a generalized obtundation that will give the clue to toxic. And there are, of course, toxidromes are a huge chapter, so we
I
won't go
understand.
into details.
Yeah. Thank you, Shobana. Thank you very much for your excellent presentation or initial assessment of neurological patient in the ICU. And we shall be continuing the same series of so-called foundation course for first year students. Um, and we'll be covering ATLS, ACLS, overview of antimicrobials, and so on.